اوكي.
دكتورة سؤال، انت راح تكملي معنا لاخر الفصل؟
يس، خلينا نبلش بالانترودكشن.
يعني مادة الفاينل معك راح تكون؟
يس ان شاء الله.
وتمام خلاص، تسلم.
أول إشي يعطيكم العافية ومساء الخير. أنا الدكتورة لين القطار، رح أكون دكتورتكم لمادة الأورال باثولوجي 2 من هون لآخر السنة، فكل مادة الفاينل حتكون معي إن شاء الله. هلا today's topic will be about salivary gland diseases. هذا الموضوع كتير طويل فإحنا قسمناهم على محاضرتين. We will cover one part today, and next week we will cover the second part. The lecture outline today, we will start with a brief introduction about salivary glands in general, and then we will talk about salivary glands developmental anomalies, and we will cover the non-neoplastic salivary gland lesions. For next week, we will talk about neoplastic salivary lesions, which is basically benign or malignant tumor for next week. Now, first of all, as you all know, the major salivary glands in the body are three pairs. We have two parotid glands, two submandibular glands, and two sublingual glands. And each one has a specific excretory duct. Anybody knows what's the excretory duct for the parotid gland?
Stenson's duct.
Yeah. So it is Stenson's duct. Usually the opening will be on the buccal mucosa that is buccal to the second maxillary molar. For the submandibular gland, anybody knows what's the excretory duct for it? Wharton duct, that's correct. And the sublingual gland is a special case. The sublingual gland has two ways of having an excretory duct. It's either one big excretory duct that goes through the Wharton duct, and we call it Bartholin duct, or it's 15 to 13 small opening. We call them the ducts of Rivenus, or the openings of Rivenus. And we also have the minor salivary gland all over the oral cavity. That's what keeps our oral cavity moist. فمشان هيك it's always lubricant. Now, of course, salivary gland have different secretions, and that depends on the type and which salivary gland it is. The major salivary glands, you have to know that the parotid gland is a purely serous gland. The submandibular gland is a mixed serous and mucus with predominance of serous secretion. And the sublingual gland is mainly, it's mixed and it's mainly mucus secretions. For the minor salivary gland, it depends where you are in the oral cavity. مثلا, minor salivary glands in the palate, hard and soft palate, are usually mucus. On the posterior 1/3 of the tongue, it's mucus. But في عنا one, like it's basically on the junction between the anterior 2/3 and the posterior 1/3, اللي هم اسمهم von Ebner's glands. These are purely serous. They're on the dorsum of the tongue. And of course, the labial mucosa, the anterior tip of the tongue, they're all going to be mixed. And you should know about the Blandin and Noon minor salivary glands. These are usually found on the anterior ventral surface of the tongue. Now, of course, the salivary flow, we have two types. There's the resting salivary flow and the stimulated. The resting one is usually between the normal, is between 0.2 milliliters to 0.3 milliliters per minute. And if the patient has a measurement of less than 0.1 milliliter per minute, this is considered hyposalivation. For the stimulated salivary flow, basically when the patient is eating, the normal stimulated flow should be between 1.5 to 2 milliliter per minute. If it's less than 0.7 milliliter per minute, it's also considered hyposalivation. Now, in general, the average person produces about 0.5 to 1.5 liters per day of saliva, and your salivation will be at its peak during the afternoon, and it will be the lowest during nighttime. That's why sometimes you wake up feeling like your mouth is dry. Now, you should know about the contribution of salivary glands to the unstimulated salivation. About 65 to 70% of the unstimulated salivation comes from the submandibular gland, 20% from the parotid, 10% from the minor salivary glands, and approximately 7 to 8% sublingual gland. Now let's start about the diseases, talking about the developmental anomalies. Developmental anomalies meaning that when you're an embryo and your salivary glands are being formed, there has been some kind of an anomaly during the development. So the first example of that is the aplasia. Basically, one or more of the major salivary glands are missing, and that is usually associated with specific syndrome. One of them is the most famous one. Anybody knows it? Okay. No. It's ectodermal dysplasia. So ectodermal dysplasia is a syndrome where everything that comes from the germ cell layer, like the nails, the salivary glands, the enamel, the sweat glands, are basically dysplastic, or that's not the correct term to call it. They're basically hypoplastic or aplastic, meaning they're missing. Another syndrome is the hemifacial microstomia and mandibulofacial dysostosis, also known as Treacher-Collins syndrome, and the lacrimo-auriculo-dentodigital syndrome. This is an autosomal dominant syndrome, usually associated with a fibroblast growth factor number 10, and usually patients will have dental anomalies and hearing loss, along with a missing salivary gland. The second anomaly would be atresia. Atresia is Latin for obstruction. It's basically the salivary gland is obstructed because of a mucus retention cyst, or also known as the salivary duct cyst, which we will cover in the next slide. The salivary gland hypoplasia is usually associated with Melkerson-Rosenthal syndrome. Anybody knows the triad of this syndrome?
Lingual on the tongue, there's fissures, and
yes.
I forgot them. بس في 3 أشياء هم.
Okay. So
fissure tongue.
Yes.
نسيت الثالث.
It's okay. So Melkerson-Rosenthal syndrome في عنا triad بيكون عندهم recurring lip swelling, also known as cheilitis granulomatosa. The second thing is the facial paralysis, and the third that you all mentioned, the fissure tongue. This is one of the syndromes that leads to salivary gland hypoplasia, meaning that the cells are hypoplastic. The ectopic heterotopic salivary glands is basically you have a salivary gland, a normal tissue in an abnormal location. The most famous example is the Staphny defect, usually within the bone, and you see it on the posterior mandible, at the angle of the mandible, beneath the inferior alveolar nerve. There's also salivary glands that were reported in the literature that are in the cervical lymph nodes, the sinonasal tract, and the external auditory canal. And of course, sometimes your glands are normal, but they have an accessory duct or an accessory lobe, and that's more common to be seen with the parotid glands. Now, the salivary duct cyst, or also known as mucus retention cyst, first of all, it is a developmental anomaly. It happens during the development of the salivary glands. It's usually cystic, meaning it has an epithelial lining. This epithelial lining, as you can see here, let me just have a pointer. No. Okay, can you see my laser pointer? هذا النقطة الحمراء شايفينها؟ Okay. So basically, we will have ductal ectasia. Ductal ectasia means dilation of the duct. There's cuboidal and columnar epithelium, and sometimes it will show pink color, which we call it oncocytic or oncocytic metaplasia. If it's larger than this, usually the diagnosis will be different to cyst adenoma, but we're not going to talk about that topic. That's basically a neoplasm. The mucus retention cyst is developmental. Okay. Now, mucocele. A lot of you in the diagnosis clinic do not know how to differentiate between those two. Mucocele is basically not a cyst. It does not have a cystic lining under the microscope. And mucoceles are not developmental. They're basically just due to trauma. The patient is biting their lower labial mucosa most of the time when they're anxious, when they're stressed. And it's the most common location for it will be the lower labial mucosa. You can also see it elsewhere, like the buccal mucosa, also sometimes may be seen in the palate. What happens here in the mucus regularly is inside the salivary gland. The mucus has been spilled out and it's basically in the soft tissue. That's why it's going to form a mass. Usually it's either deep or superficial. And what you need to do in this case is take it out, excise it with the feeder salivary gland. If you take the mucocele alone without the feeder salivary gland, it will come back. Now, how would you differentiate between deep versus superficial clinically? You can't. بس if it was a little bit with a bluish hue, إنه لونها شوي أزرق, it's more likely to be superficial. If it's deep, it usually looks like the surrounding normal mucosal color. As you can see here, this is a superficial mucocele. It's not blue, but you can see it looks like a vesicle. If it looks like a vesicle, it's an indication that it's superficial. And under the microscope, you can see that we have just like granulation tissue, acute and chronic inflammatory cells, and there is no epithelial lining like the one that we saw in the mucus retention cyst. Now, the ranula is just a special name for the mucocele when it happens in the floor of the mouth. It's usually associated with a trauma. It's the gland that is involved here is the sublingual gland. Usually it will be a mass on the floor of the mouth, lateral to the midline, and it may extend to the neck. And once the ranula extends to the neck, we change the name of it to plunging granula or cervical ranula. As you can see here, this patient has a plunging granula, and it's basically causing a unilateral swelling in his neck. Now, the next thing that you need to know as a general dentist is sialolithiasis. Sialolithiasis may be due to chronic sialidinitis or maybe due a partial obstruction. The most common salivary gland to get that would be the submandibular gland duct, and then followed by the minor salivary glands of the upper lip and the buccal mucosa. Anybody knows why the submandibular gland has the highest incidence of getting sialolithiasis?
دكتورة لأنه الدكت تورشس بتكون والجاذبية بتنزلها لتحت فبصير stagnation.
Yes, that is correct because it's long and it's tortuous and it's upward path against the gravity. So كله بيصير يكون تحت فبيصير عنا اللي هو obstruction, and then the calcium salts will lead to the calcification. Usually patients are asymptomatic. في حدا حكى شيء؟
Yes. Its secretion makes mucus more than serous.
لا, submandibular serous more than mucus.
Okay. Yes, it's sublingual mucus
Yes.
more than serous.
Yes.
Okay.
Exactly. It's just because of the duct anatomy. مشان هيك بصير عندهم sialolithiasis more. Usually patients are asymptomatic, but they will feel pain and swelling during mealtime because it's stimulated. And sialography can help you to detect the sialolithiasis. You can also do a CT, an MRI, a sialendoscopy. Sialendoscopy زي الكولونوسكوبي بيحطوا منظار وبيحاولوا يلاقوا مكان الستون. And you can, of course, do the occlusal radiographs, which is very common amongst dentists. This is how sialolithiasis look clinically. You will see this yellowish, and it's a yellowish material, and it's usually hard to palpate. And on a panoramic radiograph, if it was large enough and calcified enough, it will look like a calcified lymph node. So you have to always think about sialolithiasis when you look at panorama and you see this kind of calcification. Not to mix it with tuberculosis, because tuberculosis patients will also have calcified lymph nodes. But this is not a calcified lymph node. This is actually a sialolith. This is how they look under the microscope. Basically, we have here in the middle a calcified mass that exhibits concentric laminations like this. تشبه الشجرة لما نقطعها. And they may surround a nidus of amorphous debris. Of course, they will be surrounded by a duct that is ectatic or dilated, and there will be chronic and acute chronic inflammation that we usually call it chronic sialidinitis. Sometimes you may be lucky, بالhistopathology, you will see the feeder salivary glands, and sometimes not, حسب قد deep they cut into the tissue. But of course, you will see the periductal inflammation like the one illustrated here. Now, going to one of the common lesions that happen to the salivary glands, we have silodenitis. Silodenitis have many subtypes. We have the viral silodenitis, the bacterial, autoimmune-related, iatrogenic, radiation-induced, and idiopathic. Idiopathic being the juvenile recurrent parotitis. The viral, the most common is basically mumps, but there are other viral infections that lead to silodenitis, like cytomegalovirus, Coxsackie virus, HIV, echovirus, parainfluenza. But what you need to know is the most common, which is the mumps, also known as epidemic parotitis. The family of this virus is the Paramoxyverdae, and the genus is Rubola virus. Most commonly, it's seen in children, and it's highly infectious. It was more common before the year 1988, before the introduction to the MMR vaccination, which is the measles, mumps, rubella vaccination. But by now, everybody is vaccinated. The first dose would be given between the age 12 to 15 months, and the second dose is given between the ages 4 to 6 years. Now, mumps can happen in adulthood, but the problem with mumps in adulthood that it will have a very severe complications that will affect the patient's life. It will affect the pancreas. It will also affect testes and ovaries. Inflammation of testes is called orchitis, and inflammation of ovaries is called uveitis. And of course, these patients will be more deblated than younger folks who get the mumps. Usually we diagnose mumps according to the clinical presentation and the clinical history, but sometimes we do some antigen testing. Basically, it's the IgM antibodies in serum against the S and V antigen. S stands for the soluble antigen, and V stands for the virus bond antigen. And of course, if amylase enzyme is elevated in the blood, it may be a sign that the patient has mumps if you don't have enough clinical information. You should know that mumps is highly contagious, especially from day one, and it will continue to be contagious even after 14 days after the clinical appearance of a bilateral enlargement of the parotid has been gone. The patient will be contagious until then. Usually, almost all of the mumps cases are bilateral. Only 25% of the reported cases were unilateral. So viral silodenitis of mumps is usually bilateral. Now let's cover the second type of silodenitis, which is the bacterial. There's acute bacterial silodenitis, and if it's not treated, it becomes chronic. Another name that people like to use is the ascending silodenitis, because the bacteria allegedly ascends from the oral cavity to the parotid duct. But I don't like that terminology. I had to put it there because it's in your book. But the preferred terminology would be acute bacterial silodenitis. The most common microorganisms involved in such disease are Staph aureus and Strep pyogens. And the parotid is more common to have the silodenitis than the submandibular. Sorry, excuse me. Okay, I'm sorry. سامعيني؟
دكتورة.
Okay, sorry, بس I need 10 دقائق. Okay. Going back to ليش الباروتid more common than submandibular? Some people believe that there is a higher degree of bactericidal quality. هلا submandibular gland is mixed serous and mucus secretion. فالmucus blocks البacteria to have more effect than the parotid. The parotid is purely serous, but that's why it's more likely to get acute bacterial silodenitis than the submandibular gland. And of course, the parotid gland duct is larger than the submandibular in terms of size, اللي هي اللي بنشوفها بالoral cavity. And what you need to know in these patients, it's basically going to be at the angle of the mandible. And usually the complication would be that patients will have trismus or will have the guarding effect when they open their mouths, they try to guard their mandible from the side that it's affected. Bacterial silodinitis most commonly is unilateral, and clinically رح نشوف warm erythematous swelling, and there will be purulent discharge intraorally, and patients will report pain. This is an example of the pus that you will see intraorally, and under the microscope, it's not something that is special, but you will see chronic, it depends if it's acute or chronic. This one is chronic under the microscope because we can see lymphocytes, we can see some interstitial fibrosis, and here are the salivary ducts that you can see here. There's acini, and if it was acute, you will see the intense acute inflammatory cell infiltrate, which is neutrophils. And of course, surrounding the ducts in the acute one will have periductal inflammation. And of course, whenever you have an inflammation or an infection like the bacteria, it will lead to dilation of the ducts. Sometimes we may do a sialography, not every time, but sometimes we might need to do it. And sialography, you inject the patient with a medium that will be shown as in this color. What you need to know is that the sialography of a chronic silodinitis, when you have an acute silodinitis that was not treated or a persistent ductal obstruction, on the sialography you will see the sausaging, as you can see here. تقدروا تشوفوا الماوس ولا لا؟
Yes, مبينة.
شايفين.
Sausaging is basically, as you can see here, هون في structure, هون في dilation. Sausaging is basically the appearance that will look on sialography. لأنه chronic silodinitis is basically taking place. The salivary gland tried to heal the infection by dilation, but it failed because there is a persistent infection. Now, going to the third type that you need to know about the silodinitis, it's autoimmune related. Meaning, you have an underlying autoimmune disease that leads to silodinitis. The most common is the Sjogren's syndrome. It's a chronic immune-mediated disease. Since it's autoimmune, females are more likely to get it, and it primarily affects the salivary glands, which are that are responsible for your saliva, and the lacrimal glands, which are responsible for your tears. So patients will end up with xerostomia and xerophthalmia, and we usually call it the Zika syndrome, which is the Latin for dry syndrome. The Sjogren's syndrome is basically, it's not G mutation, it's basically associated with histocompatibility agents or human leukocyte antigens. The HLA that are involved in this disease are HLA-DR-W52, HLA-B8, and HLA-DR3. And some people believe that Sjogren's syndrome may be exacerbated with the presence of EBV or cytomegalovirus or human herpes virus 6 or retrovirus. Sjogren's syndrome is usually benign, but we fear it because there's a bad complication of Sjogren's syndrome. Sjogren patients have a higher
الصوت راح.
دكتورة ما في صوت.
شكله النت فصل عندها.
شكرا إن الشاشة كمان واقفين.
اوكي. قادرين تسمعوني؟
رجع الصوت.
فصل النت من عندي. اوكي، دقيقة ارجع اعمل شير. اوكي، لوين سمعتوا انتوا لحديت هون؟
اللي هي complications الجوجرن.
Okay. هلا Sjogren's syndrome usually is benign, but what we fear is that Sjogren's syndrome complication will be, they have a higher tendency to develop multiple lymphoma or B-cell lymphoma. That's why you need to follow up patients with Sjogren's syndrome. Now, the oral manifestations are classic. Patient will get xerostomia. They will have a red atrophic tongue. They will have this shape of cobblestoning diffusely on the dorsum of the tongue. And of course, because they have xerostomia, there is no washing effect or the buffering effect. So patients will develop caries, and they will also have discomfort, disturbed taste sensation. They will no longer enjoy food. And of course, if you have a dry mouth, you don't have enough saliva that washes off the microorganisms, you will develop candidiasis. Now, the Sjogren forms usually is either primary or secondary. This is a quick revision for your information from first and second year. كلكم تعرفوا primary is basically there's no underlying systemic disease. It's just Sjogren syndrome لحاله. Secondary meaning that Sjogren syndrome has developed due to an underlying systemic disease such as systemic lupus erythematosus, rheumatoid arthritis, systemic sclerosis, primary biliary cirrhosis. There are many of those, but what you need to know is the systemic lupus erythematosus, rheumatoid arthritis, and systemic sclerosis. These leads to secondary Sjogren syndrome. Now, under the microscope, usually you will see minor salivary glands should be collected. When you collect them, you should have at least 5 lobules of minor salivary glands. هذا يعني اللي هو احنا بنسميه accepted biopsy for diagnosing Sjogren. So when we have the 5 lobules of the minor salivary glands, we have to calculate the focus score. This is beyond your scope, but what you need to know is the focus score, if it was more than or equal to 1 per 4 square millimeter, it's considered positive. Usually, the biopsy for Sjogren syndrome, the best one would be the minor salivary gland of the lower labial mucosa. In the past, كانوا ياخدوا biopsy from the parotid gland, but this is totally contraindicated because once you do a biopsy for the parotid gland will continuously have fibrosis and you will even make it worse for the patient. Under the microscope, you will see a lot of epimyoepithelial islands. You will see ductal epithelium with proliferation and hyperplasia, and eventually they will obliterate the lumen. So I think if on the lumen add the and it will lead to islands and pools of epithelial and myoepithelial cells that are back to back, and you're going to see sheets of lymphocytes. This blue here is lymphocytes. A lot of lymphocytes will be seen under the microscope for Sjogren patients. Of course, you can do tests. The test out there, you have the ESR, which is the erythrocyte sedimentation rate, will be elevated. This is non-specific. Anybody that has any condition going on in their body will have an elevated ESR. IgG serum will also be elevated, also non-specific. The rheumatoid factor may be positive specifically for patients who have a secondary Sjogren syndrome. The ANA, or anti-nuclear antibody, is positive, but anti-nuclear antibody is non-specific. ANA positivity means the patient has an autoimmune condition of some kind, but it's not going to tell you it's Sjogren per se. هي ممكن تكون any other autoimmune condition may be ANA positive. The specific nuclear autoantibodies that you need to test for Sjogren patients is the anti-SSA or anti-RO. This is more specific and sensitive, and it's positive in 50 to 76% of Sjogren patients, with less likely anti-SSB, anti-LA. This is 30 to 60% positive in patients. Now, of course, you can do the clinical test that you all know. مفروض إنكم أخذتوها من قبل. So the one that you all have been introduced to is the Schirmer test. Schirmer test is basically a filter paper that is applied to the lower eyelid, external part of the lower eyelid. The eye should not be anesthetized. ما بصير نعطيهم هدول اللي هم المخدر اللي بحطوه بالعين, and it should be placed for 5 minutes. If the tears are less than 5 millimeter after 5 minutes, it means that the patient has dry eyes. أما التست اللي هون اللي أنتم شايفينه on the left side اللي هي pink eye هاي, this is the rose Bengal stain. This used to be used for patients with dry eyes. Basically, we put a stain in the patient's eye. هلا healthy eye will not stain. دغري the tears will wash it away. But if it's dry, it's going to stick. So if they score more than 3, في بيجي مع الستين زي الورقة اللي بتيجي مع معجون الأسنان اللي بيكون عليها ألوان الأسنان. The same thing comes with the stain. It's an index. With how strong or how intense the color is in the eye, or how intense the eye is stained. If it's scoring more than 3 according to their index, it's considered that the eye is dry. There's another stain in market, the same concept, but another name. It's called lec7 green stain. Of course, there's the clinical test for the saliva, which is the cyanometry. If they score less than 0.0 milliliter per minute, it means the patient has a dry mouth. You can do cyalography. Again, it's basically like the cyalography we discussed earlier, but the appearance is different here. You're going to see the atrophy and the punctuate sylectasia here. You can see that we have, we call it fruit ladin or branchless tree, or more likely like the cherry blossom tree, if you know what a cherry blossom is. There's a specific criteria for diagnosing Sjogren's syndrome that you should know about. They should have the autoantibodies positive, specifically the SSA, and they should have the biopsy positive for the focus score more or equal to 1, and they should have the clinical appearance of keratoconjunctivitis, ocular staining score more than 3, and of course the patient should not have any history of eye surgery or eye treatment. So this another criteria. These 2 criteria are basically one from the American and one from the European, and يعني لازم تكونوا عارفين إنه ophthalmic manifestation, they should at least have 1, and so on for the rest of the criteria that we just discussed. Now, the second autoimmune-related sialadenitis that you should know of is sarcoidosis. Sarcoidosis has many forms, but we're going to discuss the acute forms of sarcoidosis. We have 3 acute forms: lupus pernio, Lofgren syndrome, and Hereford syndrome. Lupus pernio is basically cutaneous, just facial sarcoidosis with erythema nodosum on the legs. Lofgren syndrome is arthralgia, erythema nodosum, and hilar lymphadenopathy on chest X-ray. Hereford syndrome is the one that we are concerned with. It's also called UV parotid fever. These patients will have facial paralysis. They will have bilateral parotid enlargement. They will have and they will also have uveitis. This is typical presentation of Hereford syndrome, or also known as acute sarcoidosis and UV parotid fever. They will have the bilateral enlargement as illustrated here in the clinical photograph, and here on the imaging modality, you can see that the parotid gland are enlarged and they're larger than normal, than their anatomic size. Now, we're going iatrogenic. I did not put it in here, but iatrogenic, what you need to know إنه زمان كان في شيء اسمه surgical mumps. Patients undergo abdominal surgeries and they're left without food or fluids for a long time, and suddenly they're injected with atropine. Atropine is a cholinergic agent, and this leads to the enlargement of the parotid glands, but it's no longer there لأنه تغيرت surgeries with their procedures. Now, the radiation-induced sialadenitis is basically the serous glands are more sensitive than mucus glands. So the gland that will be affected here is the parotid gland. Usually patients will have xerostomia and they will have a tender salivary gland enlargement within 24 hours of administering the radiation therapy. The radiation-induced sialadenitis is usually reported with patients who take the iodine radiotherapy, patients who undergo thyroid surgery and thyroid cancer. This is the idiopathic. Basically, it's called the juvenile recurrent parotitis. It's the second most common inflammatory salivary gland disorder in children after mumps. It's non-suppurative, meaning it's not associated with any microorganism. يعني إذا بنعمل لها culture, it will be negative for bacteria, for viruses, and it's usually either unilateral or bilateral, and it's usually resolved after puberty. Some people believe that juvenile recurrent parotitis may be of a genetic predisposition or a dental malocclusion, or may be associated with a congenital duct malformation or immunologic disorder. Till now, they don't know the specific etiology for this condition. Now, necrotizing sialometaplasia, we're done with sialidinitis. We're going to discuss this. So sometimes your minor salivary gland tissue will undergo ischemia and necrosis. It's more commonly seen in males and most commonly seen on the minor salivary glands of the hard palate. The soft palate may be involved. Anybody knows what is the etiology for this condition?
Smoking ممكن.
Okay, in the past they used to think it's smoking related, but so far the literature did not prove it. So usually it can happen when they go to the dentist and they have been injected with a local anesthetic with epinephrine, but had the injection can more than they needed, or an ischemia happened because of smoking اللي هي لهلا ما اثبتوها. فالإسكيميا leads to necrosis, leads to ulceration, as you can see here. Okay. Sorry, بدي أعمل ميوت ثاني بس. Okay. The patients usually will get paresthesia and they will get this kind of ugly looking ulcer that might alert the practitioner or the physician رح يفكروا إنه هاي cancer لأنها it's non-healing. It will heal within 5 to 6 weeks. So it's good to have it in the top of your differential diagnosis if you see an ugly ulcer like this in the hard palate that has been there for more than 2 weeks. لأنه إحنا بنعرف إنه الulcers, if they're present for more than 2 weeks, we start to be worried, right? And what you need to know about necrotizing sialometaplasia, in the beginning, they start as a nodular mass, and it will be a red nodular mass in the hard palate, and then it will become necrotic and it will have this ulceration. Under the microscope, they can look scary for an unexperienced pathologist. They will show ulceration, interruption of the stratified squamous epithelium, and of course, you will see dead acini, which is the necrotizing part, and sialometaplasia, as you can see it here. This is like a higher magnification image of a necrotic acini and squamous metaplasia. That's not normal to be seen in normal minor salivary glands. Now, the next thing that you need to know is sialidinosis. Sialidinosis is different than sialidinitis. Sialidinosis, or also known as sialosis, is a non-inflammatory enlargement of the salivary gland. It means that it's not associated with any infection or inflammation. And most commonly, it will be in the parotid gland. And the etiology is unknown, but some people believe it's associated with the dysregulation of autonomic innervation of the salivary acini or reduction in the innervation of the myoepithelial. So it's related to the nerves. There are a lot of risk factors, but the most common are alcoholism, diabetes mellitus, cirrhosis, hypothyroidism, malnutrition, bulimia, pregnancy, drugs like clozapine. Clozapine is given for patients with psychotic disorders, acromegaly, and diabetes insipidus. Sialidinosis, also, if you do a sialography, it will show the leafless tree. Basically, you have a tree without leaves, just it has branches. Now, sialuria, if you're not familiar with the name, sialuria meaning that you have excess salivation. And the risk factor for sialuria are a lot of risk factors, but the most common are the gastroesophageal reflux disease. Your salivary gland will act like a defense system or a buffering system whenever you need to purge. So you will have hypersalivation as a reaction. Heavy metal poisoning is also a sign of sialuria is a sign of heavy metal poisoning. rabies as well, medications like colzapine, cholinergic agonists, and central nervous system conditions like cerebral palsy, Parkinson's disease, amyotrophic lateral sclerosis, also known as Lou Gehrig's syndrome, and having a stroke. Xerostomia is the complete opposite of sialorrhea. Usually, patients have a foamy, thick, and ropey saliva, and it may be associated with medications. You have to know the most common medications that leads to xerostomia, which are the diazepam, which is a muscle relaxant, loratadine, which is an antihistamine. Any anticholinergic agent has the effect of xerostomia as a side effect, and systemic diseases such as diabetes mellitus, sarcoidosis, diabetes insipidus, amyloidosis, hepatitis C, graft versus host disease, Sjogren, HIV. There are a lot of other systemic diseases. This is it for today. Anybody has any question before we end the meeting?
دكتورة إيش نعتمد الدراسة؟
ايش اعطاكم دكتور فالح؟
كان يعني سلايدات وحكي.
اوكي هلا انا I do prefer يعني I know انكم بالاخر رح تدرسوا من الشيتس بس I do prefer لو انكم تجيبوا او يعني حدا فيكم يجيب الكتاب اللي هو كتاب الباثولوجي. في حد فيكم عنده اياه؟
عندنا يا PDF يعني.
خلص اوكي تمام. It's good to have it as a يعني resource available in case something is not clear in the slides or something is not clear in the sheets. فيعني بس سلايدز وحكي المحاضرة.
تمام نسلم ايديك دكتورة.
هلا في حدا تاني غير أوس عنده سؤال؟ تمام. هلا بالنسبة لمحاضراتكم خلال الامتحانات الميد تيرمز حدا حكى لكم شو آليتها؟ الكلية خبرتكم؟
أنا حكوا لنا بالنسبة للوجاهي ما في محاضرات بس أونلاين ما بعرف الأمانة.
ما حضرت.
الوجاهي كله فأكيد الأونلاين كمان نفس الشيء.
إيش حكيت أوس؟
الوجاهي مسجل والأونلاين أكيد كمان مسجل لأنه أصلا موعد الامتحانات في هسه يعني بكون.
اوكي خلص اذا هيك تمام. انا بشيك مع دكتور فالح اذا في يعني بنقدر نعمل ريكوردينج قبل بوقت او لا. اذا لا يعني نعمل ريكوردينج خلص بتحضروا later on لا تخلصوا امتحانات. تمام